let's move on and cover the lower respiratory organs: larynx, trachea, bronchi and its branches, and lungs and alveoli, likely on the next video. But before we do, we can break down the lower respiratory system into two functional zones. The respiratory zone is where gas exchange will take place, and even though we haven't looked at these yet, it will include the respiratory bronchioles, alveolar ducts, and alveoli, which are the air sacs, and then all the conduits or ducts that deliver air to the gas exchange site would be the conducting zone, and that's all the other respiratory structures that are going to cleanse, warm, and humidify the air. So the first structure we run into in the lower respiratory tract is the larynx, which is the voice box. It goes from about C3 to C6, and it has three major functions, what we're going to look at in more detail. It provides an airway, an opened airway. It's a route, or it routes air and food into the correct channels. Of course, we want food to go this way into the esophagus, air to travel this way into the trachea, which is the windpipe, and its voice production. It is the voice box, the larynx, because it houses the vocal folds. So let's run through these three functions. So the larynx is composed of 9 sections of cartilage. Not sure if you can see all 9 here, but they are, well, at least 8 of them are hyaline cartilage. The only piece of cartilage that is not hyaline cartilage is the epiglottis, which is elastic cartilage. That's what's going to become something like a trap door, so food does not go down this tube, right? That would cause you to choke, and we'll see that a little clearer later on. So the upper part of the larynx, and we can divide it with this vestibular fold right here. The upper part of the larynx is still stratified squamous, from where we left off in the upper respiratory tract, but the lower area of the larynx, so it transitions right here, is pseudostratified ciliated columnar, which is going to contain cilia and sweep mucus away from the lungs up towards the throat. So the epiglottis is the only structure of the larynx that is elastic cartilage, not hyaline. And when you swallow food, which would be the digestive system next chapter, when you swallow food, this epiglottis closes, so there is no access to the larynx. So it prevents food from entering our lower respiratory system. The larynx contains vocal folds. Vocal folds are true vocal cords, which are labeled here. You'll see a little better on the next slide. And they'll have these vestibular folds that are false vocal cords, and the vocal folds, the true vocal cords, stretch from this cartilage right here, which is the arytenoid cartilage, all the way across to the thyroid cartilage. So this longitudinal section makes it a little bit difficult to see. So on the next slide it'll be clear, and the opening created by these folds is called the glottis. So when we force air out of our lungs, we can cause these folds to vibrate, which produces sound. And here we can see the true vocal cords, the vocal folds, and then laterally to those are the vestibular folds, which are the false vocal cords. So we got true, and then the false vocal cords with the opening being the glottis. So those false vocal cords, the vestibular folds, they have no part in sound production. They help to close the glottis during swallowing. So voice production is a complex process. You can download this PowerPoint in the PowerPoint folder on iCollege and hit Control and click on this if you'd like to see a video. But it's made up of, well, speech is release of expired air during opening and closing of the glottis. How do we determine the pitch? Well, by the length and tension of the vocal cords. Loudness by the force of air that's being expired. the quality and sound of your voice by our resonating chambers in the throat, mouth, nasal cavity, in our paranasal sinuses as well. And then we shape all of this into language through muscles in your throat, your tongue, your soft palate, and your lips. So this is just a nice little guideline or summary of all the processes involved in voice production. If the larynx becomes inflamed, it would be laryngitis, usually the result of a virus. Causes changes in the vocal tone, hoarseness. You may only be able to whisper. It could be occur through overuse of the voice. Bacterial infection, tumors as well, but our general term for inflammation of the larynx, whatever the cause, is laryngitis. Our vocal folds act as a sphincter muscle as well. Remember, sphincter muscle is a muscle that is somewhat round and can close in order to shut off the opening or to close an opening. So when our vocal folds close, we cannot force air out of our lungs, and that puts pressure in the abdominal cavity. That's called Valsalva's maneuver, which you can read through here. The trachea, moving on now, is the windpipe, which begins at its proximal end where the larynx ended off, and it travels down into the mediastinum, space between the lungs, and it will divide into two bronchi, one leading into each lung. So the wall of our trachea consists of this hyaline cartilage, rings of them. There's about 16 to 20 C-shaped rings stacked on top of each other that make up the trachea, but that inner lining of the trachea would be pseudostratified ciliated columnar epithelia with goblet cells, of course, which will secrete mucus onto the surface. And then once we go through the submucosa, we get to that hyaline cartilage layer here. The adventitia is the outermost layer of connective tissue. We should note here that smoking destroys cilia. Without cilia, the only way to sweep particles and mucus out of the lungs is through coughing, because this person has lost their cilia action. When someone stops smoking, the cilia begin to recover pretty quickly. At this end of the trachea, near the esophagus, that's the food tube, we have a muscle called trachealis, and it contracts during coughing, and it expels mucus, but it can expand the trachea for food. So this muscle is what contracts or expands the trachea for different conditions. Of course, if the trachea is obstructed, it's life-threatening because that's your air route. A Heimlich maneuver, which I'm sure you've heard of, is a procedure to dislodge some material that's obstructing the airflow. The trachea ends at this fork in the road called the carina, where it branches into two bronchi. The carina is extremely sensitive, so any particle that hits it will cause violent coughing, which is a protective mechanism to force material out of the respiratory tract and away from the lungs. So the bronchi will branch 23 times, and it's considered a bronchial tree because it looks like branches of a tree. So at the tips of the bronchial tree is our conducting zone, you might recall earlier in this chapter, which gives rise to the respiratory zone. So this is all conducting zone that we see, but when we get to the tips, that it transforms from a conducting zone of air to a respiratory zone, which we'll see. So as we move through the conducting zone from bronchi to smaller bronchi, which we call bronchioles, we get structural changes from cartilage rings to no cartilage as we get smaller and smaller through branching. Elastic fibers persist throughout the conducting zone. The epithelium changes. We began with pseudostratified, that moves to simple columnar, and then finally cuboidal as we get to the small little bronchioles. The cilia and the goblet cells for mucus become more and more sparse as we move through this branching, and the opposite, smooth muscle, will actually increase as we move through the bronchioles, and that allows the bronchioles to provide a substantial resistance to air passage if necessary by smooth muscle contraction. So now we're looking at the respiratory zone structure. So we're looking at the tip of the bronchioles here. We'll enlarge that. So just at one little tip, we're getting to the microscopic part of the lower respiratory tract. So we have these terminal bronchioles, which will divide into respiratory bronchioles. And then when you see all of these little sacs, well, there's a duct in there, common duct to all these sacs, which we call alveolar ducts, which give rise to all of these little alveolar sacs, which are air ducts. Now we're inside just one of our little alveoli. So one is an alveolus. We can see the capillary bed and how intimate the capillaries are with the alveoli. So right here, for example, is our blood-air barrier. This is where air in our alveolar sacs meets a capillary. There's a cross-section of the capillary. So their basement membranes meet right there. That's the blood-air barrier, and that's where gas exchange takes place, with oxygen diffusing into the blood and carbon dioxide diffusing out into the alveolus. So the alveolar wall consists of one layer of cells, simple squamous epithelium. You could also say simple squamous epithelium. So these cells right here, where this gas exchange goes through, you can see oxygen in, carbon dioxide out of the blood into the sac. These simple squamous cells are type 1 alveolar cells. We name them type 1 because every so often we see these other cells that are more cuboidal in green. Those are cuboidal type 2 alveolar cells. They secrete a substance called surfactant, which will reduce surface tension. We'll get to that later. And also some antimicrobial proteins. All right, so to finish off this section, some other features that are significant to the alveoli. They're surrounded by fine elastic fibers and capillaries. We saw a picture of that. There's alveolar pores, which connect one alveoli to another, which equalizes the pressure throughout the lung and also is an alternative route in case there's a passage that's blocked. There's macrophages in the alveoli to keep the surface sterile, and you can see how many dead ones are carried out every hour, right, by the cilia.